Bonjour. Thank you all for getting up early this morning to hear a little bit about arthritis. So I'm going to talk about the MOON cohort experience with the development of osteoarthritis after ACL reconstruction. I'd again like to thank all the contributing centers and, of course, all the staff who make all this work possible. So I mentioned this earlier. Yesterday, the MOON cohort total enrollment was over 3,500 patients, and you can see here the 2, 6, and 10-year follow-up that has been achieved for patient-reported outcomes over that time. Of course, patient-reported outcomes are useful in telling us about osteoarthritis, but they don't necessarily tell us the entire story. So there's also a MOON nested cohort, a randomly selected cohort of patients from the MOON group that are brought back for on-site evaluation to include, as you can see below, standing radiographs for joint space narrowing, a physician examination, as well as completion, of course, of some functional testing and the patient scores as above. And that cohort is 433 patients. That cohort has been followed for 2 years, and we're currently in the process of collecting 10-year follow-up data on this cohort as well. So in those who have come back at 10 years, we have MRI data as well. And we can see, as one would expect, elevated T1 row and T2 signal in the operated knees compared to the contralateral side, essentially across the board. So as we know, arthritis, unfortunately, is following after ACL reconstruction. We also have the standing radiograph data in 133 patients at 10 years. And we do see that a substantial minority, but still a minority of patients are demonstrating clear osteophytes or clear joint space narrowing that is not present on the other side in this population, 37% with osteophytes and 23% with joint space narrowing. So this mimics some of the data that's been presented in other series, including from here in Lyon, the longer-term data after ACL reconstruction. Unfortunately, we still don't have enough 10-year data to really evaluate predictors of the development of osteoarthritis. So to talk about that a little bit, I'm going to utilize our 2-year data, which is somewhat predictive, we think, as it does fall in line with the 10-year data, and then the patient-reported outcome data at 10 years. So looking at radiographic arthritis predictors at 2 years, in the medial compartment, we again see, as one would expect, older age, meniscectomy, and then also meniscus repair were both predictive of osteoarthritis compared to the groups that had no tears of the medial meniscus. And on the lateral side, we saw some similar but different predictors, again having an elevated BMI, having had an allograft for the ACL reconstruction, which is probably associated with increased risk of failure, and then having a meniscectomy versus no tear on the lateral side were predictive of osteoarthritis. So here's a summary of these predictors at 2 years. The real interest is when we get further out. What about the longer-term results? So our specific goals today are to evaluate the effects of patient-reported outcomes 10 years after ACL, and I'm primarily going to focus on articular cartilage status at the time of surgery and the meniscus status at the time of ACL reconstruction. This is the epidemiology of the cohort by looking at the articular cartilage by compartment, and we can see that grade 2 changes were present in a 13 to 14% of all 3 compartments, and there were some greater incidence of grade 3 changes and 4 changes on the medial side. These were primarily treated with chondroplasty or benign neglect, and there were a few treated with more complex cartilage procedures, but this was a substantial minority in this population. If we look at the 10-year patient-reported outcomes by articular cartilage injury, what really jumps out is that it's the patellofemoral joint that really drives the outcomes at 10 years. That is to say, if you have substantial grade 3 or 4 articular cartilage damage in the patellofemoral joint at the time of ACL reconstruction, you're much more likely to demonstrate worse patient-reported outcome scores at 10 years. You can see the medial compartment effect is substantially less, and the effect of the lateral compartment, at least at 10 years, appears to be negligible from this analysis. Looking at meniscus tears, we can see that about 38% of the patients had a medial meniscus tear at the time of reconstruction, and 47% had a lateral meniscus tear. And you can see the distribution here, with many of these being horizontal tears medially, longitudinal tears medially and laterally, and some more oblique tears on the lateral side. These were primarily treated, as you can see here, with a distribution of repair versus partial meniscectomy versus benign neglect. And if we look at the patient-reported outcomes by meniscus treatment, it's interesting. What we see on the top 2 lines of this table are pre-existing meniscus tears. So these are tears that the patient had and was treated prior to enrollment, so at a prior time from their ACL tear. And we can see that having a prior medial meniscus tear prior to your ACL is really the biggest driver of poor outcomes at 10 years. And interestingly, we can also see that having a medial meniscus repair, certainly on the bottom half, which is the repairs that were done at the time of surgery, having a medial meniscus repair was a driver of poorer outcomes. So this medial meniscus repair, it was really of interest to us, and we wanted to delve a little further into the medial meniscus. Does medial meniscus injury and treatment really cause pain in 10 years after ACL reconstruction? And does it really matter if you do a repair or a partial meniscectomy, as our data really seem to not clearly indicate what was the case? So overall in the cohort, we didn't have a strong predictor, but on an individual basis, this really could be different, because we really know that the big driver of poor outcome is repeat surgery, and failure of a meniscus repair requiring a partial meniscectomy was one of the more common repeat surgeries in our group. So we utilized this unique framework called causal mediation analysis. And what this lets you do is really look at the impact of an exposure on an outcome, both directly and through a mediator. So you can see how this would work well looking at this meniscus repair, where we can look at the impact of a meniscus repair on the outcomes directly, and we can also look at the impact of meniscus repair as mediated through subsequent failure. So what we found when we looked at this was that the direct effect of meniscus repair versus partial meniscectomy was very positive. That is to say, there was a decreased risk of having a lower than 80 Kuss pain score at 10 years by 7% if you had a meniscus repair versus having a partial meniscectomy. However, the indirect effect increased the risk of Kuss pain by 2.9%. That is to say that if you had a meniscus repair and then a subsequent surgery, you did worse than the group that had a partial meniscectomy to begin with. So the total overall effect here kind of washes out, but that's lost if you don't delve more into the analysis. So what we can take away from this is at 10 years, if you want to have a lower pain score, you should really be selective about which patients you treat with a meniscus repair. The idea of repairing every meniscus, even one that you think has a low propensity to heal, is probably faulty, because you're going to have increased risk of failure, and that's going to wash out the benefit that you get from meniscus repairs. In the future, we want to evaluate ways to improve the success of meniscus repairs. It's important to remember that these data were collected 10 to 15 years ago with first generation and second generation meniscus repair techniques, and hopefully we do better with our meniscus repair today. So in conclusion, partial meniscectomy, older age, and elevated BMI are associated with early signs of arthritis after ACL reconstruction. Radiographic OA is present in a substantial minority of patients, 30 to 40% at 10 years. And cartilage damage at the time of ACL reconstruction has the most impact on outcomes and knee pain after ACL reconstruction when it's in the patellofemoral joint at the time of surgery. Lateral meniscus surgery doesn't really seem to be a big driver of knee pain 10 years after ACL reconstruction, but the medial side really can. If you have a successful meniscus repair, you'll have lower risk of high pain, and if you have a meniscus repair failure, these patients are going to do less well. I'd like to thank our funders, and thank you very much for your attention.